So I'd like to first start with a very general question. What are we seeking to achieve with AI? Is it just to use it to augment existing the ways we do things now, just to help them, do them more efficiently without changing how we do things, kind of having it as a helping hand, or is it rather starting to do things in an entirely different way? So a health system that looks like nothing before, or rather very different to what we had in the past. And I'm thinking, the analogy of, electricity, like whether you do something without electricity, and all of a sudden you have this like completely different things that changes everything you do. Can we start with you, Pritesh? You kind of have the big picture thinking on that is from the think tank perspective.
Thank you. So a really big question to start with. So I think just taking a step back, the challenges, as Lawrence kind of mentioned, the challenges facing healthcare systems, not just the NHS, which we tend to focus on, but many systems globally. We've got demographic shifts increasing the population age. So you've got populations that are trending older, more complex conditions, increasing costs within healthcare systems, increasing demand, insufficient workforce, productivity is sapping. And so that is a huge challenge facing a lot of healthcare systems. And AI is largely seen as a potential solution to that. Where we're seeing applications of AI is it's continuing to be thought of in what I might, and maybe Alistair kind of alluded to this, in the kind of narrow domain of existing paradigms of thinking. So very narrow focused. How does it complete a specific task? How does it do something very specific? And so if you go back to, I think it's about 2016, Geoffrey Hinton talking about radiologists, saying that there'd soon be no radiologists in healthcare systems and there'd be no need for them. And we've fast forward to today and we see actually we've got more radiologists and we've got more need for them. And part of that is because of how that technology has continued to be regulated, evidence-based, validated, put into place. Because we now do have narrow focused AI tools that do solve problems and do perform better than people on very narrow focus application areas. So what that means is that you end up with a whole host of AI tools that hospitals can choose from, but they don't do the job cohesively. So where we're seeing AI being applied is narrow focused AI around things like, say, breast cancer screening, where it does a very single task very effectively. And so that's where we're seeing technology being used for AI. Ambient voice technologies, as well as Lawrence mentioned, segmentation, so how you look at an image, a medical image, and identify features on it. But as I mentioned, we're still thinking about this in the old paradigm. So where it's being rate limited is maintaining human oversight of everything. So where's the benefit when you still need to check everything, so you still need the existing workforce? And so shifting some of the regulations that was already being mentioned is really essential to thinking about different ways these tools can be applied into healthcare systems. And happy to expand on that.
We can come back to that. What I'm curious about is whether, when you introduce something new in the health system, there's always a challenge because you have to rejiggle everything and there is a lot of resistance and, it takes forever and there's uncertainty and, lots of managers are risk averse when it's something so new that's untested. But in places like Africa, where health systems are, they just need to be, built up still, not from the ground, but kind of close to there for chronic diseases and this whole new world of chronic disease that you're facing. So I'm just curious whether AI could play some sort of help them leapfrog the development of health systems. So the way mobile phones kind of, you don't have a banking system. You never had to build one because mobile phones, completely replaced and changed the game. So I'm just wondering whether AI could do that for Africa. Are there signs that it could? And what are some examples where things might look different?
I hope so. I think so. I believe so. And I'm sitting here because of that. I've got a bit of imposter syndrome because I'm not a technology or digital or any of those specialists. I'm a neonatologist who is trying to save babies in Africa. But as you say, we need 5,000 new maternity hospitals in Africa. And we're building them one by one, but we're sort of building this facsimile of the existing system that was designed in Victorian Crimea. And I'm like, actually, we have an opportunity here to potentially think about how this could be done differently and more efficiently and from the ground up. Absolutely. Like, that's not to say that, what's working will continue working, but if we're going to invest billions and billions of dollars in this new thing, could we do it more efficiently? And that has been a very interesting thought experiment that has only increased my belief that we can. And I would extend the discussion. I think a lot of what we've been talking about is this belief that medicine is about diagnoses, and AI is going to help us with diagnoses. But when I sit in my mortality meetings every Wednesday, the reason the babies die is very rarely because of a problem with a diagnosis. It's because of much bigger systems around financing, especially around logistics, about training. And actually, I think the impact that AI is going to have is within the healthcare system. I believe, certainly within Africa, most of it is going to come in helping the system rather than the particularly glamorous aspect of making a diagnosis.
Right. Let's hear a little bit about prevention. So obviously we have apps and wearables that try to help us keep healthy, and many of them now rely on AI. What's happening there? What's your experience? Are you seeing any dramatic improvements from any particular practices, or what are the areas where AI is already starting to really help with prevention?
So Slavea, I think I can say it's incredible what's happening right now. I think there's an explosion of data. So even getting back to your first question, I think if we just end up with AI improving existing systems, it would be a huge failure. Because the behavior, the real opportunity that we see is to focus on behavior and systemic behavior quite often, but to see it how when you bring the data together and when you use it with predictive and generative AI, what it tells you about how one can really have an impact on outcomes, on the quality of health, on how people navigate the healthcare system, but also on their own behavior, and particularly to focus on habitual behavior, whether you sleep, whether you exercise, but also on doctor behavior. What are the habits of doctors and how they prescribe, and what impact does that have on outcomes? So because of this explosion of data that's available from devices, from the fact that people track themselves, and the ability to put it together in a place where you can actually now for the first time do modeling on it, that gives you real indications about what would make the biggest difference. I think the opportunities are enormous when you think about it from a systemic point of view. The key is really to allow that to happen, and then to incentivize the right behavior, where you find that sort of power in the models and in the tools. Let me just say that what we see at this stage is hallucination. I know it's mentioned all the time, but it's not an issue. We don't see that in the application of tools, and people are very worried about that. But I think it's actually now with how it's developed, quite possible and quite easy to avoid that, and still to get real insights. And the key then is to answer questions such as, if you look at a patient, if you know something about their physical activity, their nutrition, how they sleep, and whether they take their medication, what is the most important thing to tell that patient? And if you can track the data over time, longitudinally looking at mortality, morbidity outcomes, the development of disease, then you are actually able to answer that question. For you, the most important thing is to get to 7 hours sleep every night, or actually take your medication, or go for a run. These things have an enormous impact if you build up habitual behavior, and especially over a lifetime. But what we're seeing from the data is actually the impact happens much quicker than people anticipate. Sometimes within 6 months, you can see a real change. So that's the opportunity, I think.
Yeah. What I'm always curious is, when it comes to our personal data, there's the issue of obviously sharing it with whether it's your GP or wherever it's going into the system. But there's also how you link up all these systems, because AI can do miracles if it has all the data in one place, but it's all in very segmented systems in different formats, or at least that has been a challenge so far, to integrating the data to use it in this wonderful way. Pritesh, maybe you can talk a little bit about whether AI is actually helping with this kind of pull the data in ways that weren't possible before, just to be able to use it the way Emile just described.
Yeah, so it depends on the healthcare system in particular. So there are different initiatives within different geographies who are pooling data and are taking a different approach depending on culture and legal requirements. So in the UK, we've got secure data environments, we've got the Health Data Research Service, which is being set up. So there are initiatives to be able to share data. It's about the access to the data, but it's also the quality and the completeness of the data as well.
That's what I was getting at.
Yeah, so
can AI help with that?
It can help to a certain extent, but I think, to Emile's point, it can be really powerful, but we also need to recognize the limitations of it. So the AI tools will only be as good as the data. The data is a window on the world. It's not absolutely perfect. It will have bias. There are risks of the AI drifting as well. And so absolutely, we need to be able to connect up the data, which is a journey. Then we need to be able to understand what the gaps in the quality of the data is and what the limitations that implies upon the AI. And that's a loop. So that's a healthcare system loop that needs to be put into place as well. It's not just about monitoring the technology. It's about understanding what that data is, what the capability of that data is, and continuing to improve it.
Yeah. Let's talk a little bit about the infrastructure, because obviously to have something in place, you have to build whatever it needs to run on. Is the technical infrastructure for AI different than what's in place now for digital health? Or do we know whether we need to train people in a very different way, whether we need different even roles, or
this is a fantastic
that didn't exist before?
I think this is a fantastic question. So I think when we talk about infrastructure, often we talk about technology, and the NHS has some technology that is getting a bit old, let's call it, and so that there is a need to revise that technical infrastructure, as was already mentioned in the previous session, trying to understand how you monitor the validity of a system. So how the data comes in, the AI analyzes it, and the output happens, rather than a person checking everything, because then we can start stepping away from human oversight to everything to actually transforming systems. But then it's also about the social part, the human part of the connection part of it. So there's huge potential to change roles, to be able to have expertise through AI being provided to people who are in the healthcare system. So we're already seeing AI that is trained up on expert specialists for bowel cancer screening, available in endoscopy tools. That means that it upskills people who have less expertise and less training. And so we can start thinking about different models of healthcare capability, but that means different roles, different responsibilities. And just again, to Emile's point, we shouldn't underestimate what's needed for people. So how does accountability run? There's a lot that's potentially possible if you change people's behaviors. But there's a reason the GLP-1 agnostics, the Ozempics, are very popular. We talk about prevention and behavior change a lot. The technology only gets you so far. People want something that's convenient, that works for them, and just telling them not to smoke, not to do more exercise, to eat vegetables, only goes so far. That accountability and behavior change is a key linchpin in making prevention and transformation possible.
What about attitudes? I mean, there is resistance to lots of new things. That's usually one of the main drags on introducing anything new. People are fighting back because they don't want to do things differently. They're scared that what if it doesn't work, and we've invested all this money, and now it's like another system that, just sits there. And particularly in Africa, which presumably, it's a place where new things are coming out the way. I wonder whether the resistance to change is lesser than it may be in the Western world. Maybe we can start with you, Emile, first, and then we can hear from the others.
Yeah, I think there's probably many different sorts of resistance. One is just this is the way we've always done it, that inertia resistance, and that's a very powerful thing both within healthcare professionals and with patients. A more powerful resistance is the resistance of invested interests, where people realize, I may lose my relative advantage if we change there. And that is going to happen. And I think the sooner we acknowledge and accept that, the less bumpy the ride will be. To go back to your previous question, are we going to need new cadres? Absolutely. I think sort of at the most philosophical lesson, we're always going to have to, well, firstly, we have to decide, what are we trying to achieve? Like, are we trying to achieve making as much money as possible, having the current government re-elected, or to try and maximize the health of the population? And then if we decide that our goal is to maximize the health of the population, then we need to, I think, say that whenever a machine can do a function better, it should do it. And whenever a human can do a function better, it should do it. And those relative positions will change. If at the moment within my job, probably quite a lot of diagnosis could be done better by machines, but procedures, counseling, interpersonal relations, and trust need to be done by people. But back to your question, it's easier to start something new where there's a huge need and there are no competing interests. I can't say it's fail-safe. There will always be resistance, and then you also have to listen to that resistance and say, what is the issue here?
Yeah, then
is this
wrong?
Is this resistance because our missions are not aligned, or resistance because there is personal interests at play?
How are things working out from your viewpoint here in the UK? Are there signs of that resistance of, my job is going to disappear, or I don't trust AI to help me in this way, it's going to mess up things, or I just need to go and check whether things are done properly, and it's taking more time because I'm doing it twice rather than or does it even vary by
I think it's
the ways it's used? Is it more accepted now in certain areas than others?
It is more accepted in certain areas, but it varies across professions, across understanding and familiarity with the technology. So where you have people who have come together, who are working together, who have the experience of piloting the tools, testing them, trying them, using them, understanding their limitations and changing their workflows, their responsibilities, and how they deliver care around that technology. There's a lot more confidence in how it's being used. But then if we over-intellectualize a lot of this and think about it in theory, then people get worried about the risk appetite, what happens if it does hallucinate and what goes wrong, and then who's liable for these, and do I need to check everything? But the healthcare system and staff are, as we've touched on already, are really underwater. They've got a lot of pressures. The rollout of ambient voice technology shows the potential appetite for technology that supports people. And you look at the literature and the research around ambient voice technologies, and it reduces cognitive burden. It helps improve the experience. Doctors are looking at patients. There's that real interaction happening. So that's the magic that we're looking for. But what it needs is some real honesty in some respects, that we can't have people checking everything. People aren't perfect. The technology is not perfect. It's what's the acceptable risk profile. How do we move that way in a way that is assured and supported, and we continue to go on that journey rather than saying, here's the technology, right, what do we do next? It's a journey of transformation.
Right. And just to go back to prevention, I'm particularly interested in examples of where, again, going back to attitudes, because this is, if people accept it, then it works better with anything. Are there any examples of where introducing AI has really helped change behaviors? And
Yes.
I'm really looking for specific examples of
Sure.
whether it's playing some sort of like clever nudge function, because changing behaviors is hard, as we heard. That's
Yes.
why GLPs are so useful.
Yeah, I think maybe the best way to think about it's all about incentives. So attitude and incentive are very closely related. So I completely agree with Pritesh, for instance. If you look at doctors, if the incentive is to reduce bureaucracy and actually increase patient time and human interaction, I mean, the biggest barrier to that is having to fill in forms, and whether it's online or paper forms. AI solves all of that, potentially. It actually creates the opposite. Then you find, as we find both in South Africa and here, the doctors adopt it very quickly because it just makes things easier. The same with patients and policyholders. It's all about incentives. So whether they share the data with you in the first place, there could be an incentive related to that. Whether they change their behavior, it's about whether there's an incentive. People who take GLP-1s, for instance, was mentioned earlier, they want to lose weight. Obviously, that's why they're taking it. And it's interesting to see what they do then subsequently to that. Do they start exercising or not? And the answer is that some people stop, but there's others that really use this as an opportunity to change their entire lives. You can see the behavior coming through. They adopt new lifestyle habits, they start exercising. Interestingly, what we see from the data already then is that if they stop taking the drug but keep on exercising, they keep the weight off, and it's a different person with a different life expectancy. So I think that, it's not AI per se that changes the behavior. It's when it's combined with the right incentives, and it helps to solve practical problems. And it just makes people think about their own health in a different way. And it's absolutely possible to do that. That's when it has best prospects for success in changing behavior, both preventative, but actually also curative, also just taking the right actions at the right time. We see from our diabetic data, for instance, that about 95% of diabetics don't do the 6 basic things that a diabetic should do every year, despite the fact that it's fully funded. There's no barriers really, but people just don't do it. So one powerful way to change that is to say to them, you should have an HbA1c test. Do it before the end of November, and we'll give you a £10 voucher or a free coffee. Makes an enormous difference to what people actually do.
Yeah. So it's really going back to basics. So
exactly.
We shouldn't expect miracles from AI on its own. It's like a helping hand.
How you use that knowledge and analyze it to get what is the thing that changes behavior.
Yeah. I'd like to open actually for questions to the audience, just to have a bit more time. Yes, we have one here.
Hi, Tim Gosha. I run Dolmer Impact Fund, a private equity fund investing in developing countries' healthcare and AI. What we've found is the biggest difference is in diagnostics so far. And partly that's because we are prevented either from regulations or corruption from investing in government healthcare systems. So to get the innovation, we really have to go through the private sector, and diagnostics has been easy. So chromosomal diagnostics, sequencing and AI, chest scans, that kind of thing. But our hospitals are run very traditionally. Do you have examples, whether it's in sub-Saharan Africa or South Asia, anywhere, where there's really been a shift in telemedicine, AI-driven telemedicine, even remote surgery? Anything we could invest in, or any real trends in that direction?
The answer is no. But you can invest in me, and we'll do it. Yeah, so digital health is not just AI. The electronic health record and some form of telemedicine are very important. We are interested in flipping that electronic health record such that it is primarily, you could think of it as a patient app. It's the patient's portal that the healthcare system then gets access to. Another very small but early work that we are doing is using AI education as a way of training and maintaining the skills of our nurses within a very specific area in neonatal resuscitation, because that's another area where I think AI can make a big difference in low-income settings, that we don't have to do this traditional, very inefficient and obviously the professional standards still require it, but there's a huge amount of education of humans that needs to happen, and we believe we can make that more efficient using AI.
So really briefly, I think where we've probably seen it most advanced is teledermatology, and AI applications for teledermatology, but that is still limited by the quality of that information coming through. So even though we've got cameras on our mobile phones that provide really good images, it's not quite capable of doing some of the skin dermatology, skin cancer analysis. And so you still need remote hubs to be able to get you good quality information, so you don't get false negatives, false positives, and you can get robust diagnostics quicker rather than expensive staff time usage.
One question there? Yeah.
Hello. Yeah, I'm Farouk. I'm a surgeon from NHS. Pritesh, this question to you. In the system in the NHS, we see it's not one massive database. It's all fragmented and every center has its own. How do you think going forward this could be integrated into one? I mean, it would be amazing if you have a data encompassing the whole of the UK, but is there a possibility that this could be done, and how AI can help?
Great question. So I think it's very easy to say we just need to link up the data, but what data is it? Who holds that data? What the permissions are? All these things add so much complexity into something that has been conversationally important for decades. So we are seeing developments and steps forward in that. We've got the secure data environments. We've got information governance that's being put in place. We've got legislation that's going to be coming through in the NHS in the UK that's going to change some of those permissions around who can share what. We've got a single patient record coming in. So the potential continues to be there. What we need is for that to be working cohesively as a national footprint. As you kind of mentioned, we've got a term, the NHS, for 5,000, 6,000 GP practices, 200 hospitals, thousands of social care providers as well. And really everyone holds a little bit of data. And what we really need to be able to move towards is that secure data environment where we can have agreed a way forward to be able to do that. So there are plans in place. How fast we get there is another question.
Yes, please. Here in the front.
Hi.
Hi. Can you introduce yourself? Yes.
Sure. My name's Jasmine Powa. I'm a public health physician originally from Canada. Thank you for the comments. I was really interested in this idea that we do a lot of digitizing current processes in a very narrow way. And I understand that that's a way we can de-risk what we're doing. And I wonder about shifts to governance or accountability that would help us do this differently. My question in maybe having more creativity in how we do this is, what fields do you think it would be most helpful to connect with? Like, should we be connecting with anthropology, sociology, public historians, something else to maybe help us get out of some of the patterns we get into within the health system? If you had any thoughts on that question or anything you've seen happening in that way creatively.
I think to me, the most useful field has been behavioral economics. And it's really the psychology, I guess, is the ones that come immediately to mind. With the ability to test different incentives and see how people respond to it, one learns so much about human behavior and also how different types of people respond to it, and what you can tell from their past behavior what their propensity would be to respond. And again, it applies in any setting, whether you're talking about doctor behavior or patient behavior. But that's been the most useful field for us to explore. And there's a lot to understand there. It's about loss aversion, for instance. If you already have something but you're about to lose it, how do you act differently than if you were to gain something? And the answer is very differently. And it's with those insights together with the ability to then observe behavioral data over time and to focus on the delta in behavior that really gives you the insights to think about it. But all of it should always be anchored and focused on the real world and people's experience. So what we always try and do is to have a group of people that evaluates how these tools work in practice, again, whether it's doctors or patients, and tell us, is this working, and give us feedback all the time. The magic of these things is that there are no limitations to that any longer. It's conversational. So with generative AI, you can get so much information back, and it's so much easier to interpret it, even if the data is unstructured. So if it's set up in the correct way, I think there's enormous insights that one gets very, very quickly on how people respond. And sometimes it's quite surprising. Some things really work very well and others not. Cancer screening, one other great example. Again, you would imagine that the example I mentioned earlier of giving somebody a free coffee would not make a difference to whether you have a colonoscopy or not, because it's not a pleasant thing to do, and people often don't. They all know they should. And what we find is that the rate at which eligible populations do those screenings is actually pretty low, again, despite the fact that it's fully funded. But it is, again, amazing what a difference it makes just to give somebody a time limit, to say, try and do it before the end of next month. And even if the reward is something really small, it could even be an abstract reward, like a status or a gold star. Think about Duolingo. You're not getting anything back from it, and yet people go back every day to Duolingo. There's enormous advantages to be gained from that and understanding it.
It's very interesting. Going back to the incentives, that AI is not going to be the magical pill. Yeah. Any other questions? One there on the side, please.
Hello. Hello, my name is Kevin. I'm a medical doctor from Indonesia, practice public health delivery in rural Bali, currently finishing my study in global health management Imperial. My question is, there's something a bit interesting about the teledermatology that was mentioned. I did a bit of research about it. And there's questions about inequities in health, especially where AIs were put in place in the digital health systems, especially. Because one of the reasons, for example, melanoma, which disproportionately actually affects, for example, the store and forward teledermatology, it affects, there's a lateness in diagnosis, especially in Fitzpatrick 4 to 6, which is the darker skin color that you have, the later diagnosis that you have, and that implicates the people prognosis that have melanoma. So what are the things do you think that needs to be addressed? Is there we are training more data, better probably camera, or is there anything that is more systemic to address these health inequities within AI in health? Thank you.
Pritesh, can you take this one very quickly?
Yeah, sure. So really quickly, it's a real concern. The bias within technology can widen inequalities, and we're not completely sure what those biases might be. So as you mentioned, with skin color in particular and dermatology, it can be a particularly high risk. So I think there's something about where knowing the limitations of the technology. So where's the technology limited, and then how does a clinician have confidence that that's where they need to pick up using their expertise. So that's part of the safety and risk safety netting and the risk analysis. But we're also discovering new things about the biases of technology as well. So recent publication around large language models and how they provide health access information depends on what typos you have. So if you've got low language literacy, if you've got English as a second language, whatever it might be, it will give you different outputs depending on your fluency with that language. So we're still discovering a lot. So they need to be validated effectively, and the user interface and how they're designed is super important alongside the training for professionals.
Thank you. We're out of time, but join me in thanking our panelists for this wonderful discussion.
Okay.